When you think about balancing quality of life with tumor control in patients, I think for patients that have symptoms is a very easy thing to decide. If the patients have symptoms, you need to decrease the symptoms, so you start your treatment right away with a somatostatin analog initially, typically as your first line. And you go over some of the typical side effects that you expect, potentially fatigue, a little bit of sometimes a different type of diarrhea because of once you take some of these medications for a long time, it affects the enzymes that help to digest food. So you might have a little bit of a different diarrhea from your carcinoid syndrome symptoms. For patients that don't have a functional tumor or not having diarrhea, flushing, it's a little bit of a different discussion because they might say, why should I get treatment if I feel just fine? And that's when I have a conversation and go over the scans and try to understand if I have scans previously of how fast the tumors are growing, because if I have a hint either by the biology of the tumor that I'll have that information from a pathology report or from discussing with the pathology or from looking at prior scans, that can tell me how fast the tumors are growing. And then if I feel that they are growing rather fast, I think we should start treatment right away. On the other hand, patients that have a very, very indolent disease, meaning that I have no evidence or data to believe that the tumors are going to be growing anytime soon, and where a little bit of pain at the site of the injection or diarrhea can quite affect someone that is otherwise normal. In this type of patients, yes, I can't hold off and wait for some sort of disease progression or growing of the tumor before I start treatment. I have to say, though, that the majority of the treatments had quality of life data, and in the vast majority of the time, you do have improvement of quality of life with your treatment. And everolimus, which is a target therapy that some I feel that can have a lot of side effects. In fact, when they study looking to quality of life, there was no decrease in the quality of life of these patients that were receiving everolimus. So despite we having treatments that can have side effects, I think in general the quality of life wins compared to the possible side effects that we have from treatments in general. When I have my discussions with patients about treatment options, quality of life, I tell them that this is a marathon, not a sprint. So we don't have to make rush decisions. We should think about them. Often I bring them back a second visit before switching treatments to make sure that they understand what is going to be the next step. So you just have to listen to your patients and help you to decide. And it's very interesting because, for example, some patients that have, let's say, 3 bowel movements a day, they are miserable with that. And then you have to listen to that and act on that, because even for someone else, 3 bowel movements a day might not be important. For that particular individual, it is. And you should act on that. You have to respect the perception that your patients have about their health. And on the other hand, I have patients that have like 10 bowel movements a day, and they say that they're just fine. Obviously, I will recommend treatment for these patients, but it's very interesting to respect the priorities of the patients and what is their normal, and then you can make educated decisions with your patients, and always explain to them the impact that the treatment will have and why we are doing the treatment. And then do we really need to trigger that right away, or we can wait another 3 to 6 months before we make a decision? Because, again, you have to look at the patient as an individual and not just a scan. Sometimes a 5 millimeter growth in the skin means nothing. Why would you change, even though it says increasing the tumors? Unless you look at very carefully in several scans, a 5 millimeter increase is irrelevant clinically for this patient. So all these things should be taken into account when you're sitting down with the patient and the family. I like, when possible, to have a caregiver with me, because it's very interesting to also see the interpretation of the data when they bring me the data in how the patient is seeing his or her disease and versus the caregiver, I typically ask them to do diaries for me as well, so they can write down for me how much flushing and diarrhea, because they're living with the disease for so long that sometimes they don't even realize how much they're having until they actually sit down and start writing. So I try to make them very engaged on their care. In terms of questions that they should be asking the doctors, I think they should be asking how fast are my tumors growing? Should we consider any local therapy? If they have a mass close to their small bowel, is that something that is worth it to be resected? Should I see a nutritionist? I think nutrition is very important in patients with neuroendocrine tumors, so I send all my patients to have at least one consultation with a nutritionist to educate them about that, so it's very important. If you have a family history, definitely see a geneticist to help you to sort things out. Make sure to ask your doctor if you need a cardiology evaluation, especially if you have carcinoid syndrome. I think sometimes we often downplay the impact that carcinoid heart disease can have on our patients, and if you need an endocrinologist as well.